All right, well then good. So what we thought we'd do today is we would just kind of keep this pretty informal. We'll give you a very basic overview of what ketogenic diet therapy is. We'll talk about the types of therapies that we offer at UCLA, what we recommend doing before you start diet therapy, and Beck will kind of go over her role as the nurse practitioner on a diet therapy team. She'll give you just kind of a brief overview of the side effects, and then hopefully we will have plenty of time for questions and answers. That sound good? All right, so.
So I have a question. How many of you have a child or you yourself are on ketogenic diet? How many are considering, perhaps, as therapy? And how many of you are just interested in learning more about ketogenic diet in general? And what the differences are between what's currently being used in mainstream media and ketogenic diet for intractable epilepsy? Okay, good.
Sorry, my badge keeps falling off, so I'm just going to leave it here so that I don't get distracted, but everybody knows who I am, so. All right, so I know a lot of you probably have a pretty good understanding of what ketogenic diet is, but we're going to do Keto 101 for just a few minutes, okay? So a ketogenic diet is a diet that's very high in fat. It contains minimal carbohydrate, and then it has a moderate amount of protein. So normally our bodies use carbohydrate, glucose, for energy, right? We use those terms interchangeably. When a person is on a ketogenic diet, they burn fat for fuel. And when your body breaks down fat for fuel, it produces a substance called a ketone body. Right? So that is where the diet gets its name from. Now, what we know is that when we shift from a carbohydrate burning metabolism to a fat burning metabolism, this affects brain chemistry. We don't know exactly how the diet works. There's a lot of different factors that are coming into play, and there's studies that are looking into the anti-seizure and the neuroprotective effects of a ketogenic diet. But what we do know is that a ketogenic diet can be used with all different types of epilepsy, so it's not limited to one type. And so we would call that a broad spectrum therapy, right? So I'm really here to talk about the fun stuff, which is the food. So I'll jump right in. But so the primary source of calories when you're on a ketogenic diet is fat. And the fat is coming from foods like butter, olive oil, other vegetable oils, heavy whipping cream, coconut oil. The carbohydrate is going to come from non-starchy vegetables and then a small amount of fruit. When a patient is on a much more liberalized version of the diet, they can have small amounts of grains, but very, very, very small amount. And then protein will come from meat, poultry, fish, eggs, right? When your portions are actually very small on a ketogenic diet, and that's because fat has more calories per gram compared to protein and carbohydrate. So we always like to tell our families that the food should look shiny because you're adding so much fat to it, right? There are a few different types of diet therapies that you may have heard of. So probably the most well-known is the classic ketogenic diet, and then there's a modified Atkins diet. Then there's the low glycemic index treatment, and then there's the MCT oil diet. MCT oil diet is not that common here in the United States. It's used more commonly in Canada and the UK. So at UCLA, we offer the classic ketogenic diet, and then we offer a modified Atkins diet, and then we will do blended or hybrid diets if we're able, if it's medically feasible. So people always want to know the differences between the diets. With a classic ketogenic diet, that is the diet where you are using a scale to measure out all of your food to the 10th of a gram, right? Because what you're trying to achieve is a certain ratio of fat to protein and carbohydrate combined. So if you're on a 4-to-1 ketogenic diet, that means that for every 4 grams of fat that you eat, you get 1 gram combined of protein and carbohydrate, right? So if you're on a 2-to-1 ketogenic diet, for every 2 grams of fat that you eat, you get 1 gram combined of protein and carbohydrate. All right, does that make sense? So fat is the star of the show. Now, the nice thing about a ketogenic diet is, you're using the scale to get this ratio. We use meal plans, and we use a program called Keto Diet Calculator. All of your recipes are in Keto Diet Calculator, so it tells you exactly how many grams of each item to weigh out. So a typical meal would have a small amount of fruit or vegetable. It would have a protein source like meat or chicken, and then you're going to have a fat source. And we actually try to use a combination of fat. So usually we'll have some heavy whipping cream, some olive oil, and maybe some butter or mayonnaise, right? And then you weigh all of that out to get your keto prescription. Again, the calories are controlled by the dietitian, because the dietitian is creating all of the meals for you. And the meals, they're even brand specific. So if your meal says to use bacon, we're going to tell you the brand of bacon to use. So it's foolproof, right? You're following the recipe. At UCLA, we require patients to be admitted to initiate a ketogenic diet. And a typical hospital admission is probably, 3 to 4 days?
Yeah, 3 to 4 days.
Yeah. And it could be longer. It depends on the patient. And I think that's all I kind of want to say about classic keto. So we require the hospital admission, and then the other diet that we offer is a modified Atkins diet, which we call MAD for short. And at UCLA, we will do modified Atkins diets for patients who are at least 5 years old. Now, modified Atkins diet, you are eating the same types of foods as you would eat on a classic keto diet. So still very, very high in fat, minimal carbohydrate. The difference is that instead of using the gram scale to weigh out all of the food, you're just using household measurements, right? So measuring cups and spoons, we show you how to count carbohydrates, we show you how to measure your fat, and then we show you how to eyeball your protein portions. This diet we do the diet education in our outpatient clinic. It takes about an hour and a half to 2 hours, and then patients initiate the MAD diet at home, usually over the course of about 3 days. So when a child is on a modified Atkins diet, they usually get about 10 grams of carbohydrate for the whole day, and then adults get anywhere from 15 to 20 grams of carbohydrate for the day. So it's still a very restrictive diet. It is considered more flexible and more liberal, because with a modified Atkins diet, you're not having to use a scale, right? You can potentially eat out. You can eventually use some pre-made products. We do really encourage patients to cook as much as possible, because that's how you know exactly what's going into your food. And the other thing that I like to point out is that, yes, a modified Atkins diet is more liberal, it's more flexible, but it also requires for families and patients to be more independent. Whereas with a classic ketogenic diet, the dietitian is creating all the recipes, they're making all of the diet adjustments. It's a little bit easier to fine-tune the diet to the patient's needs. But regardless of which diet you choose, you need to have close medical supervision, all right? These are not like the diets that you see out in the mainstream media, right? You have to be managed by a seasoned diet team. And the other very important point to remember, and if there's one thing you remember, is that when you're on a ketogenic diet, a modified Atkins diet, low glycemic index treatment, MCT oil diet, any type of diet therapy that you're using to treat epilepsy, you have to consider it like a medication, right? Because if you have any type of diet infraction, if you cheat on the diet, it can cause a breakthrough seizure. And cycling in and out of ketosis, generally unhealthy, all right? So when you come to UCLA, we do an initial assessment. It's either myself or the other ketogenic dietitian, Sarika Siwak, who were there with Beck. If you think like, yes, I want to pursue diet therapy, we give you a couple of steps to take before you actually initiate diet therapy. And one of the big things is to change your current dietary habits. And so what we do is we recommend that you eliminate foods that have a lot of simple sugars, right? So sugar, honey, jam, any of the baked goods, ice cream, flavored yogurt, packaged snacks like crackers and pretzels, sugar-sweetened beverages. All of these foods are very high in simple sugars, and then those sugars are rapidly absorbed into the body. So we recommend that you eliminate those foods, most of which are packaged products, and then you're naturally progressing to this whole foods diet. And a whole foods diet consists of vegetables, fruit, protein, legumes, lots of healthy fat, all right? And that's kind of a nice step to take. And then we also recommend that you meet your daily fluid goal, which Beck is going to talk a little bit more about, but it's very important that patients are adequately hydrated prior to starting diet therapy and while on diet therapy. Most kids need 4 to 6 cups of fluid a day. It could be more, it depends on their weight. And then most adults need about 8 cups of fluid, and water is the ideal beverage. And that's kind of like an overview of what the diet looks like. So now I'll turn it over to you.
So typically, the diet therapy is co-managed with the neurologist and the dietitian. At UCLA, we happen to have a program where we have the diet therapy clinic, where I myself am the clinician that is working very closely with our dietitians in terms of managing the medical portion. I work very closely with the epileptologists and neurologists in terms of determining if we are going to wean medications, what medications are we going to wean. So when we see a significant reduction in seizures or seizure freedom over a course of a couple of years, or maybe sooner, then we'll decide, depending on the side effects of the anti-epileptic medications the patients are on, what medications we can start to wean. And over time, what we can do, if there's a significant amount of seizure reduction and diet therapy has been managing this, then we can slowly wean back on the ratio and see how patients do. There are some side effects. While ketogenic diet is generally safe, there are some side effects, and that's part of the reasons why we manage our patients so closely and we check labs every 3 months. So pre-existing conditions, for example, any GI or abdominal problems like reflux or constipation, this high-fat diet can actually exacerbate those types of pre-existing conditions. So we can manage it with dietary changes, or we can possibly add medications to help manage that. Other possible side effects could be renal stones, because it makes the urine so acidic, and that's part of the reason why we expect our patients to meet their daily fluid goals before actually starting diet therapy. So we push water a lot. It's kind of a big deal, but it's especially so because we do not want our patients to develop renal stones, which you can on a high-fat ketogenic diet. We also put our patients on buffers if needed in order to make sure that the patients don't wind up getting renal stones. In terms of constipation, which is a general complaint from our patients, we do manage with some laxatives as needed, and so a lot of it is medical management, medications, things like that. Am I missing anything else?
No, I mean, some of you might know this, but the diet is obviously not nutritionally adequate.
Oh, yes.
So we do require patients to be on a multivitamin, calcium, and vitamin D, and then Beck may need to prescribe something else just based on that patient's needs. We just have to make sure that we meet everyone's micronutrient needs and that we're supporting growth, or, if it's an adult, we want to make sure that we're still keeping them healthy from a micronutrient perspective.
Right. So I think we are going to open up the floor to any questions you may have specific to diet therapy. Yes?
If you're using some form of ketogenic diet and you are taking anti-epileptic medication, do you find any interactions with clients that are using anti-epileptic medication that have issues with like sodium or sugar control? Like, for example, I'm on medication that hits my sodium levels, and so I've had interactions and I've had mornings where I've had to make sure that I keep my sodium levels up, or I have to make sure that I do have an adequate amount of carbs and sugar. So I was just wondering if you would advise like a modified approach or having to look at things a certain way, because I've also tried my best to like eliminate carbs, and it's helped a lot. I've actually lost 20 pounds in 2 months cutting some stuff out.
Yeah.
So I've seen the positives, but at the same time, I've found myself in the hospital recently with a major drop in my sodium levels. So I'm just wondering if you've seen issues along those lines.
There's a couple of medications, but the one that comes to mind, I think,
Yeah.
is trileptal,
Trileptal.
which will cause the sodium to decrease, your serum
Yeah.
sodium, your blood
Yeah.
sodium. And the diet itself does act like a natural diuretic. And so are you with a team who's managing you, a diet therapy team?
Not specifically diet therapy, but I'm working through a co-hospital, and that is the medication. So I've actually gotten off it to an extent and reduced it.
Yeah.
It. I was just wondering because I've heard so many positive recommendations on this, obviously, but I'm kind of ready to involve medication. So.
Yeah, I mean, so now we would work with the neurologist, but a dip, we don't usually see that massive dip in sodium from diet.
Yeah.
We have patients add salt as needed. I mean, again, we're watching how much fluid you're taking in. And then I think the second part of your question was blood sugar.
Or just sugar in general, just making sure you have better salts too. Just some of the things that I ran into, like seeing a kidney specialist and going through like a metabolic panel and seeing like levels just dramatically altered.
Well, and that's why when you are with a diet therapy team, that's Beck's main role, right, is to monitor what we call the diet surveillance lab. So I'm glad you brought this up. So once you start on diet therapy, and most of the institutions work like us, once you initiate on diet therapy, 1 month after you've started diet therapy, regardless if it's classic keto or modified Atkins at UCLA, we see you in our diet therapy clinic. After that first appointment, we have you come back 2 months later. And then we see you about every 3 months thereafter. Prior to every appointment, Beck is ordering labs. She has specific labs that she looks at for diet therapy to make sure that you're safely in ketosis. And then if you are having any type of side effect, whether it's a low sodium or whether or not you have crystals in your urine, which could show that you're at increased risk for kidney stones, then the team will work with you to help manage those side effects. So that's we're trying to optimize ketosis in the safest way.
Right. So you brought up an interesting point, because we just had a case just like this where the patient's sodium, he was hyponatremic, he was in the 120s, and we did try and supplement with some sodium, and we definitely watched in terms of his fluid intake how much fluid he was taking. But ultimately, I think we started weaning off of the trileptal because we found that was the culprit. In answering the hypoglycemia, right, or low sugars, so patients on ketogenic diet will have lower blood sugars than typical people that are on regular diets. So our blood sugars typically range anywhere from the 50s to the 80s. That's somewhere where we like our patients that are on ketogenic diet. But that's normal because now we are using fat. We're burning fat as fuel versus glucose. Did we have a question over here?
Yeah, so
And then you're in the back.
we just started the modified Atkins with a 6-year-old, and we have a 2- and 4-year-old, and so we decided we're going to all do it, but measure her and just kind of, we haven't been keeping track of any of us. And I know my 2- and 4-year-old are getting carbs at school, like applesauce, bread, whatever they're giving her at preschool. So how do we manage our safety on the diet? Because we're not being looked at, we're not having labs, we don't even know if we're in ketosis. So how do we manage this safely? Is it okay? Like, is it not okay that we're all doing this somewhat? I mean, we're eating the same foods, but we're measuring hers and just eyeballing ours. Is that a bad idea?
No, so I'm sorry. So she is being managed. Your 6-year-old is being managed by a ketogenic diet team. So the question is whether or not everyone else is achieving ketosis, right? Where you are producing enough ketone bodies. And Jen and I were just talking about this because a lot of people are following in mainstream media a somewhat ketogenic diet. The question is whether or not you are following it in such a way where you are producing ketones. And so, she's being managed very closely. The question is whether everybody else is being managed very closely. There are symptoms where you are in too high of ketosis. There's like nausea and vomiting, things like that, that you would notice in yourself.
Yeah, I was nauseous for weeks.
I would recommend, and what you're doing is the ideal situation. I mean, you want to be able to have family meals, right? And also, like, if you're the cook in your house, you don't want to be doing separate meals. But what I do recommend is it's not safe for you guys to be doing what she's doing. You can still have the same foods, but make sure that you're having a lot more of the vegetable, a lot more of the fruit. As long as I know you probably don't want to eat grains in front of her. If she doesn't care, then it would be okay to have a little bit of grain. Otherwise, just double up on the vegetable, double up on the fruit, double up on the protein, so that you're eating the same foods but not going into ketosis. And don't add the fat.
Is it okay for us to be doing the ketogenic diet or no? Or we're not doing keto, we're just doing the modified Atkins, so.
Well, but modified Atkins technically is a diet that produces ketones. But no, I mean, it's fine to eat the same foods. And I think that in general, that whole foods diet where you are eating, you're avoiding all the packaged stuff, which it sounds like you guys are doing, and Beck was just saying this, so that's just like such a great diet for everyone, the ideal diet. But no, we would never recommend someone to be on a ketogenic diet and not be medically supervised. So for you guys, don't add the fat, eat the same foods, but you're eating more of the protein and carbohydrate. I mean, her food should look shiny. Her protein portions should be very small, and you're adding so much fat that it should look shiny. Yours shouldn't. Does that help? And I know there was somebody in the back. Sorry, back there.
After you've been on the ketogenic diet for several years, how important is it to monitor your ketone levels, like the blood versus the strips? You've been using the strips. Is it would be beneficial for her to
I think once you've been doing it for several years, you know your own body, right? And so for the most part, you know whether or not you're in ketosis or when you've accidentally had something and it's kicked you out, right? So once you've done it for several years, you know your own body. It is still very important to have those metabolic labs drawn at least every 6 months thereafter, even though you've been on it for years, to make sure that yes, you are still in ketosis, but metabolically everything is still safe.
Okay, there's not those meters would be more of a specific.
For the first, so the keto sticks that you pee on.
Right, it would help her if we got one of those meters to try and maybe, go ahead. Would it be able for us, or if you have findings of someone having better relief in a certain ketone range, or?
Not necessarily, and it's how your body responds to your level of ketosis. Somebody might be on a 4-to-1 ratio and respond really well, or be on a lower ratio and respond really well, or a higher ratio and respond really well. And we don't necessarily force the ratio up for better seizure control. We maintain you at where your level is best maintained.
Okay.
Yeah.
I saw this one, and then I saw someone over here. So we'll do 1, 2, and then 3, 4, 5. Don't.
7, 6. Okay, remember your number.
Don't get upset if we get out of order.
So, am I going?
Go ahead.
Okay, so I'm speaking from adult starting. Okay, so it's myself and 2 adult daughters. We all were dealing with epilepsy. And we all looked at using modified diet, and my daughters discussed using it, and I told them that because I didn't start early, I wasn't feeling like this was the right thing for me to do, to try a strict program. I had been diagnosed when I was 30, didn't know about the diet and wasn't feeling like this was a program for me. But I cut back on carbs and did all these things just on my own and kind of headed that way, but not strict, just improving my diet all over. And they did a much more tight diet. So it kind of sounds like as adults, even we should maybe try to find a nutritionist and do this.
Yes. I mean, I'm probably the wrong person to ask because I would never say no, the ketogenic dietitian.
I mean, they're in their 30s.
Yeah. No, yes, you should. We see adults at UCLA as well. You should definitely.
Yes. So interestingly, because this diet was all prior, to recently, is used in children with intractable epilepsy, and with recent research in the literature, now we're using it in adult patients with epilepsy, and we're actually coming out with a consensus statement on how to manage adult patients initiating ketogenic diet and looking at their long-term outcomes. The thing is that historically it's been pediatric centers that have been managing ketogenic diet. Our center happens to manage pediatric and adults, which is really nice. For example, Hopkins, which invented the diet essentially, they have two different centers. They have a pediatric and adult center. So now with their adult center, the peds patients transition to adults, or adult patients initiate in the adult center. So it really depends on your location. If you're local, there are some adult centers, like USC is one of them. Yeah, so then I would look into where perhaps there would be an adult center that
I
could.
just found out that one of the cooperatives is moving into our area, so it's only going to be an hour away instead of 4 hours away.
Sure. And with our adult patients, while we manage them closely, we don't necessarily manage them as closely as our pediatric patients. And so once you've gotten used to the diet and it looks like your labs are stable, perhaps you won't need to be managed as closely as pediatric patients.
And are there specific foods that you have to avoid? My husband read something about maybe I shouldn't be eating eggs as much. Seriously?
Yeah, I mean, we use eggs a lot on the diet. I mean, it's a really excellent source of protein. Sugar alcohols are contraindicated on the diet, so that can be in a lot of sugar-free products. But no, I mean, what you're really limiting is carbohydrate. And then actually limiting carbohydrate is challenging, but what we have found is that it's actually getting the fat in that is the biggest challenge. Yeah. Does that answer the question? Yep. And the Charlie Foundation has a list of all the keto centers, and so those keto centers will be able to say whether or not they work with adults.
Oh, so just more information. Actually, there's a lot of really great information on the Charlie Foundation website. The Charlie Foundation website is really a testament to what parents can do. They pretty much hold all the keto, just like this event today. So a lot of literature and a lot of research is coming out of the Charlie Foundation. But if you're looking for a center that provides ketogenic diet, the Charlie Foundation has one, really good resources, and then two, who the ketogenic diet centers are in the nation.
And who to contact.
Thank you.
All right, who was number 2? Yes.
I understand it's a non-technical therapy, but I just wondered if you had any studies that were done on actual brain malfunctions. So my niece has epilepsy, so she has infantile spasms, and we've been looking into keto. So I don't know if you have patients that
We have a lot of patients.
Yeah, so a lot of our patients that fall under the umbrella of epileptic encephalopathies, so LGS, Dravet, infantile spasms. We have quite a few number of patients that are on ketogenic diet, and when we initiate it early, they seem to have some pretty good outcomes. Obviously, it's synergistic, so the effects are, with medications, we tend to have some pretty good outcomes in that particular disease state. So yeah, we do have quite a few patients.
Who's three?
Number three.
Just wondering, how can we measure ketones on our own without going to a medical center?
So ketones on your own, and obviously we want you to be closely followed. There are keto sticks that are available at your local pharmacy, and so it measures the amount of ketone bodies that are excreted in your urine. And so that's one way to take a look at your level of ketosis. There's a specific ketone body. So now this is blood work that we do. It's called beta hydroxybutyrate. So the beta hydroxybutyrate tends to correlate on as to the ratio, right, that you're on. Similar.
Theoretically.
Yeah.
Yeah, but
and so what we look at to make sure that our patients are in ketosis or an adequate level is by measuring their beta hydroxybutyrate, but that's in the blood. I mean, in terms of measuring it on your own, that would probably be the only way to do that with the keto sticks.
And what is the goal? Like, what is your target as far as how many ketones?
when we're medically supervised, when you're on a medically supervised diet, I mean, again, we really don't, we would not recommend for someone to do a ketogenic diet on their own. It's simply not safe, and the diet is not, it's not just not nutritionally adequate. But so when we do it, you're looking for...
We're usually looking, in terms of urine, we want moderate amounts of ketones. But again, the BHB number doesn't necessarily matter. What matters is the how the person is responding to diet therapy. So we would never say necessarily that we want you to reach a BHB of 4 if your seizures are being managed at a BHB of 1. So we're not necessarily targeting a specific number, but in terms of those keto sticks, we look for moderate amounts of ketones in the urine.
Because at the end of the day, the first question Beck is asking in diet therapy clinic is, how are seizures? You know, are they better, the same, worse? And that's all we care about. So if your seizures are better, and let's say your BHB is less than a 1, right? So it's not technically a therapeutic level of ketosis. That's a win, right? Then you have improved seizure control, and that's what you want at the end of the day.
One more thing. When I learned about the ketogenic diet being done at Johns Hopkins, my understanding was that they would put the babies on the diet for maybe 2 years and then wean them off it, and some of them would be seizure-free. Is that the same game plan for adults?
We wean somewhat, and it really depends on the patient. If they achieve seizure freedom for 2 years, then we tend to liberalize the diet and then slowly cutting back or increasing the number of carbs rather, and seeing how our patients respond. Some of our patients have had breakthrough seizures, and so really it depends on the person. We can't necessarily say that yes, we can completely wean adults off of the diet. We've had a couple of kids, right, that we've been able to wean.
Definitely children can, in our experience, yeah absolutely. That they've had seizure freedom, and then you're able to wean them off successfully. But adults, it's a different story. Our goal would be to, even if we couldn't come off the diet completely, to be able to get the patient on the most liberalized version of the diet for them to sustain.
And have the best control possible on the most liberalized version of the diet.
It's just like a medication, right? You want to try to take the lowest dose that's going to be therapeutic. So,
Thank you.
who was 4?
I was 4.
Oh.
But with that was part of my question. So on a keto diet, so it's kind of like you start off kind of, I guess, level, first keto diet, then you maybe have seizure control, and then you modify like a stepping stone, so to speak. And then so the person is, I guess, maybe seizure-free or not, but then say they're seizure-free with including their medications that they're on. So this would be like a lifelong diet, I guess, that they would have to be on?
It depends on the patient. I mean, I'll be very transparent. You know, we have some patients that have been on the diet for 10 plus years, right? I mean, it's going to depend on the individual. We've also learned, you know, ketogenic diet or diet therapy has evolved a lot over the past 20-something years. And so we're learning that, you know, a liberalized version of this diet is not as unhealthy as we thought it was if it is properly managed and supervised. So I want to make sure your question is answered. So, you know, the goal is always to wean, but if the patient has to stay on some version of the diet to maintain seizure control and they're willing to do it, then we will work with them to do so. I mean, our goal is always to get seizure control and maximize quality of life.
That helps, thank you.
Did you have another question or?
Good one, and I forgot it.
Oh, that's okay.
Was there number 5?
Oh yeah, was there a 5?
I don't remember what number I was.
Oh, but you had you were in the queue.
Okay.
I see you back there.
I have 2 questions. So I have my daughter, she has acardie syndrome, infantile spasms. She got diagnosed at 5 months. We tried the ketogenic for about 2 years because I really pushed it. But she was also on all kinds of anti-seizure medication. So, and it wasn't really seizure control. So now we're on no medication. We do just CBD, Miriam soap, and a combination. We're back into the keto. Now it's been since the beginning of the school year, so September. What are your thoughts on exogenous ketones? Is that something?
It's coming up a lot in conversation. We don't have any of our patients using them. So I don't have like personal anecdotal evidence. I see the theory behind it. I mean, again, dietitian, I'm always going to push for food as much as I can. So it's interesting. We're definitely following along, but I don't have a good answer for that. There are also the palatability. I mean, you know, if it's ketone, I mean, it smells like what's it, nail polish remover, like acetone.
Like acetone.
Yeah, so I'm curious as to how they would deliver it. And I see these products out on the market, and I don't want to go down this rabbit hole, but in general, we really try to avoid packaged products, especially these keto products. I mean, some of them are better than others, but some of them, when you look at the ingredients, they've got 6 grams of carb. For a keto cookie. Well, if you've got your kid who's on 10 grams of carbohydrate for the whole day on a modified Atkins diet, that keto cookie isn't going to do it. So, and then you said you had second question
is you had made mention about the MCT oil. So currently her keto dietitian has recommended to add, basically prescribes 6 tablespoons of oil per day. And to add 1 tablespoon per half a serving of keto cal. So she has a 4-to-1 ratio. It was interesting because I give her 3 times a day MCT oil, but you had said that UCLA is not very, or you made mention about the MCT oil type of diet. So I was kind of confused on
that's my fault. Sorry. So there is a separate diet called the MCT oil diet, which we do, I don't have anyone on that, but we use MCT oil, which is medium chain triglyceride oil, right? It's a type of fat that is it's medium chain, the name, and it's metabolized very efficiently, and it makes ketones very efficiently. So we use it to optimize ketosis. We use it on probably 95% of our patients, and that dosage sounds pretty standard, and we treat MCT oil like a medication. And so we will more than often, add it to patients' diet to optimize it, and it's a lot of people prefer it because it's tasteless, and the consistency is it depends, because some people can't tolerate it, so it's very individualized. But it's very commonly used. Thank you for bringing it up.
What brand would that be?
There are many different brands on the market. So Bulletproof, I think, has a lot of really nice ones. We've used XCT oil, which I think is the one that we often recommend. But Nestle has an MCT oil. Bulletproof has a couple of different versions. So you just want to, if you are working with someone, just have the dietitian or the neurologist or nurse practitioner check it out.
You have a question? Yeah.
Is it possible to
Oh,
be
yeah.
on, is it possible to be on a ketone diet if you're already on a gluten-free, dairy-free, soy-free diet?
Yes. It's, I mean, the diet is very easy to do gluten-free, pretty easy to do soy-free, and the last one you said was dairy-free.
Dairy. Yeah, because you mentioned butter.
Yeah, I mean, you can
Something
use a
else.
lot, you'll just use a lot of oils, a lot of avocado. We can use ghee, which is a clarified form of butter.
Okay.
So it's definitely feasible. Yeah, definitely.
Yeah, this may be basic, but what if your child's epilepsy is already broken for that medication? Is it necessary? Because my understanding was this is for the part that's intractable, so then people add the keto to kind of help with the medication. Is that right, or you know what I mean?
So the question is whether or not ketogenic diet is typically used as first-line therapy for epilepsy. So, in my experience, it's not typically first-line therapy for epilepsy. There's
Well, it's only if the medication's already working.
Yeah.
Like, does it help to also be on ketogenic diet?
Well, so if you have a patient that's on monotherapy on a single anti-epileptic medication and that is managing seizures, then we're all for it. But it also depends on the side effect profile of that particular medication. But if that is what's controlling seizures, then great. Then we want our patients to be on that single medication. We haven't. I don't know. Well, we've got a couple of patients where their monotherapy is the ketogenic diet, but that was after trialing AEDs first. Yeah.
So, question?
Yeah, and I'll come to you. But I think what would be really a really nice combination is to do the whole foods diet, so to just try to eliminate the packaged products, food products, because people see a lot of benefit in that. So some people see a lot of benefit in that, and it's such a healthy diet.
Yeah.
So that would kind of be a really good starting place, and it certainly wouldn't do any harm. Yes. And
So
then,
maybe the same question, but asked differently. So what kind of patient is on the keto diet?
So typically the patients that come to us have they've failed 2 AEDs, so 2 anti-epileptic medications. At that point, you can try a couple of therapies, right? So we can try more pharmacologic medications if there is an area of focality. So some of you might have gone to the surgical talks, then we can work up a patient to see if they are a surgical candidate to resect that portion where the epilepsy is coming from. The other option is vagus nerve stimulators. So some of you may have it or have heard of it or have a child that's on that. And then the fourth option typically is ketogenic diet. So after our patients have failed 2 AEDs, then after that, that's kind of the algorithm that the epileptologist or neurologist would fall through.
I think the gentleman in the back in the plaid may have had a question. Did you have a question back there? Sorry.
It's kind of hard to hear back here, but anyway, so I'm sorry if I mentioned this already, but so a single medication seems to be working. My son is 17, and you don't have to be in full ketosis to get benefits from this type of diet, right? Is that kind of what you guys were just saying?
That is true. Like we were saying in the beginning, the mechanism of action for the diet, it's still not fully understood. So it's really just shifting to that fat-burning metabolism that is shown to be really helpful. But again, like some patients may not be at a therapeutic level of ketosis, and they may be seeing some benefit. Alternatively, patients may require a very high level of ketosis to get the seizure control that they want. So it just depends. And that's why, like in my own mind, I break it down and I think, well, so everybody needs a different dosage of a medication, right? Some meds work, some meds don't.
I think what we're saying though is that in general, for patients with epilepsy and for all of us, a whole foods diet is a good starting point. And it's a good point to look and see, well, is there seizure reduction just in eliminating these processed foods and, you know, eliminating the amount of sugars that you're ingesting, and then from there, I mean, if there's a significant seizure reduction, then there's a good chance that perhaps ketogenic diet might work.
The movie I saw, Charlie's Story, was like from, I don't know, 20 years ago. And what John Hopkins said was that the ketogenic diet was a cure, not just a treatment, but a cure for children that were like maybe 2 years old or less, maybe 3 years old or less. Is that still true?
There are certain patients who are super responders, in which case Charlie, you know, thankfully he was a super responder. So the diet worked really well for him, and we have had cases like that. But
I mean, they're taken off the diet and they never have another seizure, and that's without medication.
Right. So it varies. You know, I mean,
seems like it should be a first approach.
I wouldn't say the majority of our patients are like Charlie, but we certainly have responders.
New young babies, it would seem that they should be all put on that diet on the chance that they can be cured.
Yeah.
That's actually a point that we didn't bring up. It just made me think of it because babies often take formula. If you do have a patient, if a patient is dependent upon a feeding tube, there are ketogenic formulas that we will use. Keto Cal, Keto V. If for some reason a patient doesn't tolerate a conventional formula, at UCLA and other centers too, we can try to do like a home blenderized keto formula as long as it's medically feasible. We do have a few patients who are thriving on home blenderized formulas. So that just jogged my memory when you said that, but I think you say it better than me that it depends on the patient, and it's like a lot of our patients are using it with medications.
Right. I mean, we do have, so in the neonatal ICU, we do initiate diet therapy on a select number of patients, so very, very young. So there really isn't an indication for infants, you know, less than 12 months of age, but we are closely monitoring these patients, and if indicated, we'll start babies on ketogenic diet. Yes.
So my question now is, we're on modified, they want us to do keto in December. Is there a significance between the modified and the keto? I mean, if she's, that was one of the questions, we're seeing that she's at moderate when she does the on the stick.
Yeah.
Is there a need for her to be at a higher level? I mean, we haven't had any EEGs, we've only been doing this for about 3 or 4 weeks, so what are your thoughts on that? Like, can we just stick with the modified? Do we have to go keto?
Well, you can interrupt me. So my first question would be, have you seen any improvement in seizure control with the dietary changes that you've made?
It's hard to tell. She has absent seizures, so we've seen an improvement in energy, but we also switched some of the drugs around. She's on 2. And we think we're seeing less, but we thought we weren't seeing any in July, and she's having 60 a day. So we don't know until we get that EEG.
You bring up a good point, actually. So the point is that we try not to make too many changes at the same time because we can't really identify what caused the seizure reduction. So we try not to manipulate the medications and diet at the same time. We try and do things one at a time to try and determine, well, gee, what is really causing the seizure reduction? I think, and you know, Jen had brought this up earlier, the ketogenic diet, classic keto, is essentially foolproof. So there isn't as much room for error on the classic ketogenic diet as there is on a modified Atkins diet. And you can speak to this a little bit more.
You know, I like both diets equally, and when you look at the research, the research will say it's not necessarily that one's more efficacious versus the other. You know, and I do like them equally. The nice thing about the ketogenic diet is that the dietitian, the team, is controlling those recipes. They're tweaking the fat. It's quite nice if you need assistance with meals. And you know, and if you're following it, then there's no room for error. right? Well, or very little room for error. And so, at the end of the day, I don't know how the medical center that you're working with does it, but like we ask for it, and Hopkins does the same thing. It's a 3-month time commitment. That's like the standard, so that you can, it's 2 months.
They were just saying, let's do it in 2 months, because they haven't seen any progress with any of the drugs. So they're like, we'll go to keto, we'll just start this first. My concern is, she's 6, she hates the diet. We're big on fruits and vegetables, but she can't really have a lot of those. So she hates all the fat alternatives. She's never been really introduced to a lot of fat stuff. So I need ideas of how to get her to like things that are fat.
She like heavy whipping cream?
She's getting sick of it already.
Yeah.
So
I mean, that's the thing. If you have someone picky, I kind of go back and forth over this, right? And dietitians will tell you different things. I think like a classic keto diet, it can be kind of nice for the picky eater, or unless it's a picky eater who's willing to eat the same thing all the time, and then modified Atkins. And that's the thing. You can give it a try, and then you can always go back. So it's not like you're not like stuck. So it's individualized. It's nice if you have the team really helping you. It sounds like you have a diet therapy team. It sounds like they have a plan in place. Did we answer your question? I'm so sorry. I kind of was going.
I guess I just wondered if we can get the same results from the modified to the. I'm assuming it's going to be a harder diet to follow, that she's going to like less on keto, but I don't know.
Everyone's different. I wish I could give you a more exact answer, because we've had people where we were worried about that, and then the keto diet worked really nicely. And then we've had people that were like, oh no, we got to transition to modified Atkins, and they've done really well. It seems like just the brief overview you're giving us, it seems like a reasonable, don't you think, like a reasonable thing to try and to give it a good shot, get her into a good level of ketosis and see if you can get some control.
I mean, if she's already there, what are we aiming for strong instead of moderate?
Well, you don't know until you do a beta hydroxy. You need to go and have lab work done, and even that, it's one value in time, right? So you really want to do 3 months and have her in a good level of ketosis.
Before we say, oh, this therapy didn't work for her.
Yeah, give it a good shot, nice clean shot.
Is there still a lot of heavy cream with a traditional ketogenic diet?
There can be. I mean, it's patient preference. So I think the gentleman over here was asking if it could be done dairy-free, and we can, which means you wouldn't be able to have any cream. We would be using more oils, avocado.
So if there are any additional questions, we are at the UCLA booth. There's some more information about our diet therapy program, and so feel free to come visit us if you have any more questions. Otherwise, have fun out there.
Thank you very much.
Thank you. It's so cold up here. I'm like freezing. Oh no, it's ours.
Oh, is it yours?
It's ours. We had someone bring some
Oh, that's right, goodies.
So my daughter's a patient.
Oh, he's in here.
She's doing it.
So she is.
Well, my wife, my wife can take those.
Oh.
I had a question. Well, she just started CPNP.
His child is Macy.
Yeah. Macy, I got this.
I'm Jen White. Nice to meet you. I'm Eleanor.
Yeah.
No.
She's here. Well, we just playing, roles right now. She's going to the other ones. So just a quick update.
Hey,
There she is.
my husband?
Okay.
Yeah, it's so cool. I know she's is it Dr. Beck? I'm like,
Not a doctor.
Yeah. So yeah.
Okay, so how long was the medication?
Started 2 months.
September 7th.
The French people are here.
They were, yeah, I talked to them, well, I spoke to them a little bit, I told them like, it's pretty good.
Well, it almost kind of seemed like it did at first, but it was niacinamide and like combination. I don't. Breakthroughs are the stairs, but so herbs are sometimes. Okay. But yeah. We see it sometimes. Yeah. Yeah. What was I saying? She graduated from high school, so and she's a so there's things that we have. I'm so grateful, you know. But it's one of those things like I don't have this grandfather's everything. It's a problem. But then when I went to the hospital, like, you don't know this. It's hard
Cool.
because like I wanted to go through.
Awesome. Are you the next speaker? Yeah, that's me. I will go ahead and pick up some. That's okay. Good, thanks.
Sorry, I was looking.
Yeah.
Thank you so much for being here. Do you need anything from us before you start?
Thanks. Put this in a pocket or something. Yeah.